This is the case of a patient operated 10 years ago by us, and she gave a history of injury by fingernail by while she was playing with a little child, and probably complained of watering and irritation for a couple of days 3 years ago. And slowly she said that she had noticed her spectacle power was changing until she came for follow-up. On examination, we saw there was a dense epithelial ingrowth. Maybe she had flap avulsion and flap got stuck again, which led the epithelial to grow inside the flap. On doing an anterior segment OCT, we found that the epithelial ingrowth had become very fibrotic and adhesive, especially to the flap area, and the thickness of the growth was approximately 120 microns under the flap. So we proceed by isolating the flap margins, and you will notice that what I've done here is I have not lifted the complete flap. Now, while you lift the flap in these cases, you have to be very careful because of adherent fibrotic patch. If you are very aggressive to peel away or separate the flap in this area, you can probably cause a buttonhole, which you will notice here. I'm trying to do it very gradually in a controlled manner. You can also see the liquefied stroma or the corneal stroma here, which is coming out as white fluid. But there is a specific patch which is very adherent in that area. I'm trying to break that patch. You have to be very careful. While you remove this, you have to depress the cornea downwards. If you even slightly lift the corneal flap while trying to break this fibrotic adhesion between the epithelial ingrowth, the flap, and the corneal stroma, you might end up creating a buttonhole. You have to depress the corneal area while you break this adhesion. You will notice that now I'm pressing the cornea downwards and trying to break these adhesions. I will approach from all the sides slowly, and now I'm finally able to break it in. And as I lift up the flap, you will notice that there is a part of the corneal flap which has actually got totally dissolved and melted along with the fibrotic. You will also notice that I have not lifted the flap completely, because if I lift the flap completely before I clean up the whole epithelial ingrowth area, I had a fear that I might have some loose epithelial cells and liquefied cells which might percolate into the other unaffected area of the flap and may cause a recurrence in that area. After I've lifted the flap, I do a dry debridement of that area, aggressive debridement of that area with a dried myrcene. This initial debridement has to be done very carefully, and most of the movements are directed outwards from the epithelial growth towards the periphery. After I have done the debridement of the corneal stromal bed, now I do the debridement of the corneal flap. You have to be very careful when you're doing this, because you don't want to actually tear the corneal flap. Now again, once the cornea is slightly dry again, I use a curved blade, a 15 number blade, to debride a deep debridement of that corneal stromal bed. The same part is repeated again onto the undersurface of the flap. Now this has to be done very carefully, because this, if it is done a little bit carelessly, can cause a complete cut of the cornea and can also cause the buttonholing of that area. You will notice that there is a defect of the corneal tissue underneath the flap. We wash the undersurface of the flap and the stromal bed. After washing of the stromal bed, we again very carefully and in a controlled manner continue to debride the stromal bed. Now this step is mandatory, because if we even end up leaving some amount of epithelial cells, the chances of recurrence in these cases are very high. Once we've done the debridement, we again wash and deposit the flap. Now this process has to be done very gently, because if you notice that in one specific area of the flap there is a deficiency of the tissue underneath. What appears as a buttonhole to you in this video is actually not a buttonhole. In fact, it is a major part of that area is the epithelium, and the corneal tissue underneath the flap, just beneath the epithelium, is the one which has got liquefied. Now, that is one thing which you cannot help, because that liquefied and fibrotic part of that flap is now removed. Now, after this, you start ironing out the flap outwards. Now, once I've seen that the flap fits in properly and there is no epithelial defect and buttonholing, now just to get the proper repositioning of my corneal flap again, I will now lift the flap completely off from the stromal bed to get a proper alignment and not induce any astigmatism. If I just lifted half the flap and repositioned it without lifting the other half, there was a chances of slight misalignment. Now I have lifted the whole flap after I've cleaned the epithelium, washed away all possible traces of the epithelium from under the surface of the corneal flap. Now I proceed to actually dry the ledge or the gutter around the corneal flap. This part of ironing has to be done very carefully and meticulously, because you don't want any fluid to be caught underneath this corneal Lasik flap, because it might have some inflammatory cells, liquefied corneal stroma, or some epithelial cells which may cause increased inflammation like DLK or a recurrence of epithelial ingrowth. You will notice a gentle, controlled outward ironing of the corneal flap. Another thing to take care is ironing over that area which has already gone thin due to liquefaction. That has to be done very carefully, because there is a very thin of epithelium and just a small amount of corneal tissue underneath that area. That area of defect which is there in the corneal tissue has to also be ironed, but a little bit carefully and gently. It's not a bad idea to debride the epithelium on the limbal side of the flap also, so as to ensure that there are no epithelial cells on that part of the corneal flap edge which may cause epithelial ingrowth again. Once I have stabilized the corneal flap in its place, I will debride that remaining part of the tissue away from the flap and move the Mirocele sponge away towards the limbus to cause separation of epithelium. I am causing some debridement of epithelium on the side where there was an epithelial ingrowth to ensure that this epithelium, if there is any other loose epithelium here, it is pulled away from that area of the flap edge or the flap gutter. I'm using a hockey stick, which is often used to deepithelize the cornea, to peel away any loose epithelial tissue in this zone. And now we can see there is some loose epithelial tissue there. Once all the cleaning is over, we wait 3 to 4 minutes for the whole area to dry up. This will increase the adhesion between the corneal flap and the stromal bed, and then we proceed to put a bandage contact lens, which is a long duration bandage contact lens, because sometimes you may need to keep this contact lens on for a week or so. So we wait for 7 days for this patient, and on removal of the contact lens, the whole area is absolutely clean. And here you can see the pre-op and the post-op image, and the patient is doing very well.